welcome everybody. Since I've already covered chronic tonsillitis and chronic otitis media, I'll be covering the other topics which are usually given for long case and short case for a third professional MBBS examination. So today's topic of discussion is deviated nasal septum. So the points on which I'll be talking about are introduction, etiology, types, clinical features, the clinical tests to diagnose a deviated nasal septum, and investigations, and obviously the treatment of deviated nasal septum. So what is deviated nasal septum? We know the nasal septum consists of three important parts: the columellar septum, the membranous septum, and the septum proper. The septum proper forms the main osteocartilaginous framework of the nasal septum. We should have a good knowledge about the anatomy of the nasal septum, because you may be asked many questions regarding the anatomy itself when you get deviated nasal septum as your long case. So any deflection from midline, of the septum from the midline is called a deviated nasal septum, as the name itself suggests. So coming to the etiology of deviated nasal septum, the commonest cause of a deviated nasal septum is trauma. Now the specific point to be remembered in trauma is this also includes the birth trauma or even the trauma that occurs in intrauterine life. What happens is, suppose the pressure is created on the nasal septum which causes microfractures of the osteocartilaginous framework of the nasal septum. So microfracture is an important word which you must remember. Microfracture in intrauterine life or even during delivery during birth, we may miss these traumas, and basically they may later on in life may give rise to a deviated nasal septum. So this is the first causative factor. The other important factor which causes a deviated nasal septum is developmental defect. We know the nasal septum develops from the pectoseptal process. You must remember this as well. So any abnormality in development may cause a deviated nasal septum. Then again, another important factor which we must remember is, if there is a discrepancy in development between the skull base and the palate, the septum may be crushed between the unequal growth of the two ends. So that may also cause the deviated nasal septum. Now, a few other etiological factors which may be considered are racial factors, like deviated nasal septum is more common in Caucasians, and of course hereditary factors like DNS may run in families. These are just you must remember these two, but these two are more important, trauma being more important. Types of deviated nasal septum. So the deviated part may involve the cartilaginous part, the bony part, or may involve both. So coming to the types of deviated nasal septum, so this is called an anterior dislocation. what happens here is the septum proper is dislocated from the columellar septum. This indicates the columellar septum, and as it is dislocated from the columellar septum, it moves into any one of the two nasal cavities, reducing the space on one side. So this is an anterior dislocation. Then coming to a deformities of the septum proper, which forms a C-shaped deformity. So this is a C-shaped deviated nasal septum. Similarly, if the septum proper has deviations on both sides, it is called an S-shaped deviated nasal septum. Now, this is very important. This is what we call a septal spar. Now, a septal spar usually occurs in the junction of the bony and the cartilaginous part, most commonly. And then finally, this is a thickening of the nasal septum. Thickening may occur due to previous septal hematomas or septal abscesses which has occurred previously, or there may be small fractures of the septo-osteocartilaginous framework which may override on one another. So basically what happens is, suppose this is one part, another part has fractured and moved on this previous part. So the width of the septum will increase. So this is thickening. So these are the types of deviated nasal septum. So the clinical features of deviated nasal septum. The first and most important clinical feature that the patient will present with is a nasal obstruction. To be more specific, initially the patient will present with a unilateral nasal obstruction. So initially the patient presents with an unilateral nasal obstruction. Later on, that nasal obstruction may turn into bilateral nasal obstruction. Why that happens, I will be explaining while describing turbinate hypertrophy. So then these symptoms are all linked, so I will go on explaining them back to back. So what happens when initially there is an unilateral nasal obstruction? What happens is the nasal airflow reduces. Nasal airflow reduced. So what will happen? The adhesion of the osteomeatal complex and the sinuses on that side will also reduce. So as the adhesion and the ventilation of the sinuses is reduced, it will lead to a sinusitis. So it will cause recurrent sinusitis. A deviated nasal septum, long-term deviated nasal septum, will go on to cause recurrent sinusitis. And then again, when there is reduced airflow, the patient has developed a sinusitis, it will cause nasal blockage and nasal discharge. So the nasal blockage will in turn cause a eustachian tube dysfunction. Will cause ET tube dysfunction. And the discharge may also go in through the eustachian tube and reach the middle ear cavity to cause otitis media. So it may cause otitis media with effusion or as well as an acute otitis media as well. Then coming to headache. Now the important point about headache that you must remember is the headache is most commonly associated with a deviated nasal septum with a septal spar. What happens is, suppose this is the spar, this is your superior turbinate, this is middle turbinate, inferior turbinate. Now, what happens is that nerves passing through the nasal cavity may get compressed by this spar. What happens is the nerves supplying the sphenopalatine ganglion, coming from the sphenopalatine ganglion, when they are compressed because of this septal spar, may cause a specific type of headache which is called a Sludder's neuralgia. Now, Sludder's neuralgia is not specific for deviated nasal septum. Sludder's neuralgia can occur in any dysfunction of the nerves going to the sphenopalatine ganglion. This is one of the causes. Like the headache resembles what the headache which normally occurs in Sludder's neuralgia. Then coming to hyposmia, what happens is, so as the nasal airflow reduces, the amount of air reaching the olfactory region of the nasal mucosa is also reduced, which may cause symptoms of hyposmia. If it is a severe case of deviated nasal septum, long-term deviated nasal septum, then it may also present with anosmia. Now then the patient may also present with epistaxis. Now epistaxis here is recurrent repeated epistaxis. What happens is, as the septum is deviated to one side, so the air entering the other side is way more than it should. So what happens is, there is drying up of the nasal septum on the other side, which may cause increased crusting. And whenever there is formation of huge crusts, it will cause the formation of more raw areas which predispose to epistaxis. Then coming to turbinate hypertrophy, what happens is, whenever the septum is deviated to one side, the airflow on the other side is increased. Now we know that the inferior turbinate is highly vascular and it helps in maintenance of temperature of the coming air. So since the airflow is highly reduced on this side, this turbinate has to compensate for the other side. So the main regulation of nasal airflow is done by the other nasal cavity. So overworking of the turbinates may cause compensatory turbinate hypertrophy of the opposite side. So they will become large in size. So this is why an initial unilateral nasal obstruction may become a bilateral nasal obstruction. Then coming to the final clinical feature is cosmetic deformity. When the deviated septum is so severe that the external appearance of the nose is also deformed. So we may be able to see the nose to be deviated on one or either side. That is called a deviated nose, and we normally require more than a septal correction surgery to repair that defect. So clinical tests and investigations to diagnose a deviated nasal septum. Initially, what we can do is, we can lift up the nose like this and we will be able to see the vestibule area, and normally a caudal deviation like in anterior dislocation of septum can be diagnosed only by lifting up the nose like this. Then coming to anterior rhinoscopy is done. So first is for caudal deviation, then coming to anterior rhinoscopy. We know anterior rhinoscopy is done by a thudicum nasal speculum, and we can very well visualize the deviated part if it involves the anterior part of the septum by anterior rhinoscopy. Then coming to two important clinical tests that you need to perform whenever you get deviated nasal septum as your long case or even your short case are the cold spatula test and the Cottle test. Now, what is the cold spatula test? We'll take a tongue depressor and place its horizontal blade in front of the nostrils, and we'll ask the patient to breathe out. So what will happen is, so this will be your nose, these are the two nostrils, and the tongue depressor will be like this. So whenever the patient is breathing out, since this is a cold instrument, there will be mist formation in front of the two nostrils. So whenever there is a reduction in airflow on one side, the mist formation on that side will be less than the other. Now, an important thing to remember about the cold spatula test is nasal cycle. So what is nasal cycle? Even if there is no deviated nasal septum, the airflow may reduce in one nostril and it will be more in the other. So only small amounts of differences in the misting of the tongue depressor is not considered to be reduced airflow. Whenever there is a huge difference, like there is almost no misting on one side and there is huge misting on the other side, may indicate a reduced airflow on this side. So that is more indicative of and it indicates that there is a chance of deviated nasal septum. So then coming to Cottle test, what happens is in Cottle test we test the functioning of the nasal valve. Now what happens is, in Cottle test, suppose this is again your nose. So these are the two nostrils and this is the septum. So if there is the deviated septum involving the nasal valve area, so even a small deviation can cause a severe obstruction when the deviated nasal septum involves the valve area. So what happens in Cottle test? We press the cheek and pull it laterally. Whenever we pull it laterally, the nasal valve area will widen. So whenever there is widening of the nasal valve area, there is a huge reduction in symptoms of nasal obstruction, and that indicates that there is a chance that the patient may become better after a surgical treatment of the deviated nasal septum. If there is no improvement of the symptoms in a Cottle test, there is high chance that there is a valvular defect and the correction of the deviated nasal septum might not relieve the symptoms after surgery. After the clinical evaluation of a patient of deviated nasal septum, the investigations that need to be performed are, now coming to the gold standard for diagnosis of deviated nasal septum is DNE. So what is DNE? DNE is diagnostic nasal endoscopy. So this is the gold standard for diagnosis of a deviated nasal septum. Now what are the other tests that you can perform? That is radiological tests. We can perform a X-ray, although that has a very low value in the current setting. X-ray of the PNS, and more importantly a non-contrast CT scan of the PNS. Now these are not always required. If we have endoscopy, we may need not perform the radiological investigations. So these are the investigations that you need to perform to diagnose a case of deviated nasal septum. To the treatment of deviated nasal septum, now there is a huge controversy about medical management of a deviated nasal septum now, but still I will be mentioning it. The treatment is mainly surgical, but when there are small deviations of the nasal septum and we are not very sure whether the surgical treatment will relieve the symptoms or not, a trial of medical management should be done, because a deviated nasal septum causing compensatory hypertrophy of the inferior turbinate on the other side and congestion of the mucosa, they may be treated conservatively. So those, if the patient has adequate reduction of symptoms of after proper medical therapy, we might not need to go for a surgical treatment. That is why this part is very controversial, but the important thing to note here is when there is a discrepancy between the size of the deviated nasal septum and the symptoms that are occurring, there is a higher chance that the patient has a different pathology, like the patient may have a chronic rhinosinusitis or a allergic rhinitis. So for that we need a medical treatment with decongestants initially. We must remember that decongestants like xylometazoline or oxymetazoline should not be used for more than 7 days, because that may cause rhinitis medicamentosa. And of course we can also use intranasal corticosteroids. And to reduce symptoms, antihistaminics as well. Now coming to the surgical treatment, the two important septal correction surgeries that we perform are the SMR or the submucosal resection surgery, submucosal resection surgery, or the septoplasty. Now this is the most important part which you should learn very carefully, because this is a very commonly asked question where you have to describe the differences between the submucosal resection and the septoplasty. It is a very important question, not only for the students who are getting this as a long case or a short case, but for your grand viva as well. Now, so I'll be discussing the differences between the two surgeries in a whole chart. So I'll be going to it shortly. So coming to the difference between a submucosal resection surgery and a septoplasty. Now before going into the differences, the first thing that you must remember is the septoplasty is a more conservative surgery and the SMR is a more extensive surgery. So initially the difference in the incisions. Now in submucosal resection we give a Killian's incision, and in septoplasty we give a Freer's incision. What are the differences between the two? The Killian's incision is slightly cephalic to the caudal end of the septum, and the Freer's incision is caudal to the caudal end of the septum. So that is the caudal part of the septum is the marking above and below which we give the two incisions. Now one thing we must remember about the Freer's incision is it is also called a hemitransfixion incision. So a hemitransfixion incision. Now coming to the anesthesia, like since SMR is a more extensive surgery, we can plan the surgery to be done in local anesthesia, but for extensive surgery it is preferable that we do in general anesthesia. Even for septoplasty it can be tried in local anesthesia, and since it is a shorter procedure than submucosal resection, so normally we can do it in local anesthesia. So this I mentioned initially only the type of surgery. This is a very extensive surgery, that is a more conservative surgery. Why is this extensive? So while performing a submucosal resection surgery, after the incision we'll start lifting the mucoperichondrial flap. Basically we'll be separating the mucous membrane and the perichondrium of the osteocartilaginous framework, basically the perichondrium as well as the periosteum from the nasal septum proper. So when we will be lifting the mucoperichondrial flap, so it will be completely separated, and we'll only keep a small 1 centimeter gap near the dorsum of the nose of the bony cartilaginous framework, and towards the caudal end we'll leave a small bit. Rest of the septum between the two mucoperichondrial flaps, why two? Because the mucoperichondrial flap on one side and the other side, everything will be removed. Only this short strip 1 centimeter here and 1 centimeter below will be left. The other everything will be removed. So that is a submucosal resection. So the name suggests itself, below the mucosa will be removing everything. So that is submucosal resection. So what does this lead to? Like, since this septal cartilage is the only support, only dorsal support of the nasal septum, so there may be a dip in the nose, like this dorsum may be like this post surgery. So that is called a saddle deformity. So that predisposes the SMR operation predisposes the patient to a saddle deformity more. Now, why is septoplasty more conservative? The initial step is similar. After a Freer's incision, we will elevate the mucous membrane with a Freer's elevator, and we will only remove the part which is deviated. We will only remove the deviated part, and then the flap will be placed on itself. So the chances of complications or the external nasal deformities occurring after a surgery is much less. So this is a more conservative procedure. So why is SMR operation avoided before 17 years of age? Because the points of ossification of the cartilage are not fully developed before this age. So if we perform a SMR operation before 17 years of age, the patient may develop with long-term deformities because the new ossification centers may arise and the deviated nasal septum may recur. Now, septoplasty can be done in children as well because we only remove the deviated part when we do not damage the ossification centers. Now, another important thing that you must know, since although SMR leaves a higher chance of formation of complications, the surgery is more secure. Like, why? What do I mean by more secure? Like, the chance of a redeviation occurring in SMR operation is almost nil. But however, post septoplasty we may need to perform surgeries repeatedly, like the deviation may recur. So both of them have their advantages and disadvantages, and it depends on the surgeon which surgery to perform on which patient.